And I have control of it. Oh, I have control, so I can share the screen, right?
Okay, so I think we have a good number of folks joining us, and I think I'm going to get started in the interest of time because I want to make sure that we have enough time to listen to Darrell's presentation and have some room for questions and discussion. And Darrell, you're probably figuring this out, but I always get into this Zoom Quandary, you're in presenter mode, so just giving you that heads up.
So how do I get, so
sometimes what you might want to do, I learned, is before you share, start your presentation and then pick the non-presenter side.
okay.
Yeah. Shanitra has seen me do this many times.
God almighty.
Technically troubleshoot my Zoom sharing.
How many people with doctorate
PowerPoint
degrees does it take
yes.
to do a presentation?
You quickly figure out who has mastered Zoom and PowerPoints and the combo. Okay, and while Darrell is negotiating with Zoom and PowerPoint, I do want to introduce him as actually one of my mentors. He is the first person who ever introduced me to palliative care over a decade ago. And for that, I am incredibly grateful. It started my whole career trajectory in palliative care. And it was the medicine that I thought I would be practicing as a medical student going into the field. And it took me finding palliative care to really find, I think, the medicine that I wanted to practice and thought I would be practicing. And so Darrell was really instrumental in leading me down this path, actually. So he's remained an inspirational mentor to me throughout my career. He's won numerous awards. He's appeared at many national conferences. It would take me all day to list all of the accolades he has built up during his illustrious career. But I think really, just on a personal level, again, I think he's served to inspire the community around him and countless many learners and trainees like myself who have had the benefit and privilege of working alongside him and with him. So with that, I do want to hand it over to Darrell. Oh, and just I am really grateful to have Darrell on today because I feel like I'm kind of scooping Jerry Powell podcast on which he has appeared a couple of times and will appear again, I'm sure. So thank you, Darrell, for agreeing to give this really important talk. I think many of you have heard me mentioning the overwhelming grief and sadness and moral distress and stress that we have all been encountering during the pandemic and continuing to encounter even now. And so I think it's a really critical topic that we all need to hear about. And with that, I'm going to let Darrell take it away.
Okay, so I'm still fiddling around with this. What are you seeing? Everybody, you're still seeing all the
Still seeing
people?
the gallery. Mm-hmm.
Okay, hold on. I have two screens up, and so that's been part of the challenge.
Oh, I know your pain, Darrell. That was
there was just previously, Darrell, that you were sharing that had you at full screen. So whatever you had previously done, we had seen your full screen presentation, and then you clicked off and we went back to gallery view.
What do you see now?
Looks full screen to me.
There you go. I think that's it. Yeah.
Okay. So let's go. Okay, we're there, right? Everybody can see it. Sorry about that. So thank you, Annie, for that lovely introduction. I feel like I'm in good company here as I look kind of all through the folks who are here that I have worked with in the past or currently work with, or maybe will work with. So, from a historical perspective, this is my 20th year at UW. I spent 10 at Harborview, launching that service. And then I went to Northwest to help launch that service, taking someone who's on the screen with us, Katie Poignier, went with me. And I've been up there 10 years. And it was always my intent to go back to Harborview, but that didn't happen. I really love the campus up there. And I felt like Harborview was in really good hands with lots of folks there. So, how did I get interested in this? This is now my 30th year in hospice and palliative care. And I started in San Francisco in 1992 during the AIDS crisis. And this is when time to death from being HIV positive to dead was about 18 months, right? This was pre-AZT. This was horrid. It was an absolutely horrible experience. We didn't know what to do. We were trying. Hospice was, at that time had still kind of evolved into really just oncology. And now we had 20-something-year-old young men. And it was a horrible time. People were coming to San Francisco to, seek treatment. They were coming to seek acceptance. This kind of predates power of attorneys, and we didn't really see the pain until people's families from around the rest of the country would show up, and all of a sudden they would take over, and partners would have no say-so anymore. And it truly, that's when Ken Doka started to look at. Dr. Kenneth Doka has done significant research on disenfranchised grief. And, that's kind of really where it got thrown in everybody's face, right? That this is what disenfranchised grief looks like. Now, forward to the pandemic, the current pandemic, COVID. And so we did a little something different, just for a little bit of background. On the Northwest campus, we're in a high percentage of elderly folks in North Seattle. And so in March of 2020, when the first case showed up in Everett, all we had was Wuhan data, right? So we had the data coming out of China, which maybe we were skeptical of, maybe not, but it's all we had. And so what we did know was high percentage of deaths, elderly people who did get it were doing the worst. If they got a ventilator, they weren't surviving, and we had nobody who survived CPR, but likely at that point, nobody had even gotten CPR because they were not there. So we started to get some data from Italy. And so we said, we are going to be inundated and overrun on this campus. So I collaborated with Dr. Tonelli and Steve Mitchell from the emergency department at Harborview, and we put together a plan, and we said, we have to be able to talk to people early on and have somewhat of a rushed goals of care. It really wasn't a goals of care. It was really an informed consent process as to what treatments do and don't work for COVID. And this is March 2020, where you still waited sometimes 12 hours to get a test result, right? People were PUI, right? So if they were symptomatic, that was one of the challenges. So I said, okay, how long can this possibly last? It's only going to be 90 days and we'll be done. And so I said, all right. And it's kind of a myth to say there's a palliative care service on the Northwest campus. It was me at the time. Our palliative care team was laid off 4 years ago because we don't make any money. And so they laid everybody off except me. And I was too old to lay off. And so I said, all right, I'll screen these people 24/7. I will come into the emergency room. We will have I will have a conversation with with the families, patients if I'm able, but it turned out majority of them had major neurocognitive disorder. So it was conversations with families. People were scared. And so it was probably 65 days straight, 24 hours a day. Some nights I spent the night in the hospital because it was just too hard to keep driving back and forth, even though I'm only 10 minutes away. And so really significant. At the same time, we decided that the hospitalists were really going to be inundated. So I expanded to be an admitting service. So every single person on Comfort Care was admitted to the palliative care service for management. And so that's admission, management, discharge summary. So managing the whole team, and we offloaded the hospitalists from that. So in the first 65 days, I screened, I don't know, I've kind of lost track. To date now, it's probably about 270 people. But it was intense. I did it for 65 days, and it was the best work of my career, actually. I have never felt more needed and meaningful contribution than I have during that period of COVID. It was like, wow, this is what it's like to be, right? And you don't have time to kind of sit back and think, and what's this like and what's happening. I just knew it was important and it was meaningful. And it was a team, right? We were a team. The nurses were working together, the hospitals were working together. It was amazing. And sad all at the same time. So we finished that surge, first surge 1, and kind of, we go through the different stages of surges. But with each surge, as you all know, there was loss, right? And it wasn't as much as the loss that we were experiencing from patients, right? Now we see nurses leaving. Now we see providers leaving. Now shifting, right? So surgery stopped, we put on the brakes, people bring us food, everybody claps for us. And then it's like, okay, get surgeries done. Open up these beds. We need revenue. We need revenue. Get the surgeries in. Get the surgeries in. And it was like that, right? Like an instant click until the next surge. And there's, oh, we can't do surgery again. And so this yo-yo that all of us were experiencing, because if you were in practice, you were experiencing this, and it was, it was so, and then the emails, got burnout. I think I spent more time reading got burnout emails than I actually did with self-care. And it's funny, when I did my first Jerry Powell podcast right in the midst of this, beginning in March 2020, because several other institutions across the country copied our model on the Northwest campus for palliative care and ER intervention. So we were trying to get the word out there as much as we can. And I did another Jerry Powell podcast where they said, yeah, I feel like I get so many emails telling me that I shouldn't be burned out, that I'm burned out reading emails about not being burned out. And so that kind of was this across the board piece. So I got to the point, now fast forward, I've signed just over 100 death certificates of people with COVID, more than any other nurse practitioner in the state of Washington, and the third highest for all physicians and nurse practitioners in the state of Washington, and have cared for well over 100 people who died on service. And and as an institution, we're proud to say that no elderly individual during those first surges died on a ventilator. No one died getting CPR. They all died on comfort care with their families supported. We had one death way post third surge. That was quite disheartening. He came in, looked pretty good, and the hospital, it was a Sunday morning, literally. And I talked about this on the podcast. I was like, I talked to the hospitals. He's like, look, he's really stable. And I said, I really just want to stay home and read the paper. Well, that was the wrong day to stay home, because before I could get to him, he died. He was still full code at that point. It was a code. It was awful. And again, one of the only times I had cried during that point, because I just felt like I failed my team. I failed the hospital, and certainly this patient, right? Because no one did an informed consent discussion about how useless this was going to be for him to do this. So, so challenges there, but the culture of the organization is still changing, right? The Northwest campus, if you've ever been there, had longevity. One of the reasons I stayed up there from Harborview is many of the hospitalists had been residents, and I was there attending at Harborview when they were residents. When they were on the palliative care service, I was there attending, right? I was the director of the palliative care service there, and they would come on and I was there attending. So I knew many of them, and I liked the feel and I liked the community culture, but that was changing, right? The building was the same, but the people inside and the culture of it were not. And I started to just, I was having more and more trouble. It was like, I was short, I was snappy, and then I was getting oh my gosh, you must be getting burned out. You must be, and I knew that that couldn't be the case. And so I said, this has got to have something to do with grief. And so I reached out to someone that I've known in the past. His name is David Kessler. He's a grief person. This latest book, I think, is Finding Meaning. And I said, I don't get, and he said, oh, you know what, come to I have a program. It's a grief educator program. come to this program and we'll do it on Zoom. And it's the first one I've ever done. So I started taking a deep dive in grief. And it was at that point that I said, wow, I'm not burned out at all. I'm grieving, right? And my mourning behavior, not what I do in the morning, but my mourning behavior, M-O-U-R, was my go-to was anger, right? I wasn't crying. And so that was all this manifestation. And so then he said, well, why don't you, join me, do some co-facilitation. And then I embarked on a educational path that's now been well over 500 hours of clinical time in grief and another 400 didactic hours, and got certified as a grief counselor. And now am working with 2 doctoral students on a national study of disenfranchised grief in the nursing community, right? We're going to do all of healthcare, but we're starting in the nursing community because this is so incredibly important and so unrecognized. So that's how I got to this emphasis and focus on grief. And so that's where we're going to go from here. So, some of the general terms, collective grief, which I'm sure you've all heard of, is, it can be any community, and it really depends on how you define the community. So using myself as an example, I'm really talking about my work community, one that I had truly loved enough to leave Harborview, which I truly loved, to be up there. But it can be the result of anything. So think of collective grief. It can be death, right? It can be a devastation of a natural disaster. Think about what's happening in Florida right now. And what happened to the world that we knew as normal, right? Prior to the pandemic, the collective world, right? Where we came to work. I have colleagues, I have never seen their face. I have never seen below here, right? New hospitalists have joined us, new nurses. I swear if they walked by me on the street, I probably wouldn't know and they didn't have a mask on. If they had a mask on, I'd know immediately who they were, but I don't know who they are. How is that normal, right? We've made it normal, but that's not what we're used to, right? And then we also think about the lives that have been lost, right? So I just flew back from Charleston this weekend, and people are all like on the airplane without a mask, not me. And I'm wearing this mask, and I'm just like, one, I've never had COVID, knock on wood, that I'm aware of, and I feel like I'm not honoring all the people who died that would have worn a mask or would have been vaccinated had they had the chance. They died prior to that, and I just feel like that's just my kind of way. I don't scream at people anymore about what are you doing? Why don't you? Are you not vaccinated? All of that, but I do think of kind of the collective grief that comes with it. And so think about your colleagues, your institution, what that looks like for you, right? If you haven't read The Year of Magical Thinking by Joan Didion, it is spectacular. Spectacular. She died, not of COVID, but she did die. And grief turns out to be a place none of us know until we reach it. And it was sure true for me. 30 years in palliative care, I understood grief, right? I've gone to CEUs on grief. I knew what grief was. And when my father died, I felt what grief was, right? All of the sudden, and then my father and my grandfather, and then another grandparent, and they all, 3 or 4 had dementia. And now all of a sudden it's like, wow, that's what it's like. How many times have we all talked to somebody who's losing a parent whose parent's dying of dementia, right? And yes, you lose it in stages. Well, until you walk that path, it makes you it puts you in a totally different perspective. And it certainly did for me, right? So you can know at classroom and experiential wise is a totally different thing. And I learned this early on, something that David Kessler taught. We live in a grief illiterate world, right? And we work in an absolutely grief illiterate profession. And I have totally discovered that when I said, we're going to embark on a national study on grief, and I'd like to kind of pilot it amongst the nurses here. I was told, no, I think you better do it nationally. I don't think that's a good idea. I just think that we've got too much going on here. Yeah, we've got a lot of grief going on, right? Stop saying people need to be more resilient. Stop saying people are burned out. Get informed, right? Stop being so grief illiterate. And if you haven't figured it out, I am not very politically correct. So sometimes the message gets lost in the messenger. But just even knowing, like, how many of you have even been familiar with the term disenfranchised grief? Like, what does that mean, right? So And it's applicable every day, but when you see more of what we do, we are not very literate. So, you know, it's not a disorder, it's not a disease, it's not weakness, right? And if your morning behavior happens to be crying and you're in healthcare, you learn how to stuff that right away, right? Because it just, you know, oh, no, can't cry in front of anybody. It's not safe. They don't want to see me cry. So that's kind of a behavior that's not allowed. And the only intervention for grief is to grieve, right? It takes more energy to avoid it than it does to actually experience it. And the only way through it is you have to walk through it. So, you know, if we look at the formal, this is just the grief definition itself. Formal definition, it's neuropsychobiological response to any kind of loss, right? We think of it in association with death, but that's only one and actually not the most common form, right? So there's all kinds of losses. There are symbolic losses. There are tangible losses. There are non-tangible losses. And one of the most dismissed types of losses is pet loss. Pet loss, right? The number of times I've seen elderly people in the hospital who have said they were leaving AMA because there is nobody to take care of their pet and then be totally disenfranchised because that's not really important. Yeah, well, if you're 80 something and that is your whole life, that's all you have is your pet. Yeah, that's exactly where your priority is going to be, right? And I like to think of grief as a no judgment zone. I like to think of it as a no judgment zone. So it's a loss. And so really have to incorporate that into symbolic versus non-symbolic, tangible versus non-tangible, and it's unique. It's unique to the individual. So what's a loss for you may not be a loss for me. And what I was experiencing was the loss of the culture of my organization, which was compounded kind of by the loss of individual friendships, you know, the loss of what I believe to be normal. In 2020, my son was a junior in high school. Then, you know, he didn't have his senior year in high school. So there's so many losses that we experience that I experience that you don't, and they're not comparable, right? And so it is about a loss or a change we did not want, right? It's a lost connection. Broaden that scope when you're talking to people and when you're thinking about yourself, right? Because this isn't an in-service of this isn't grand rounds about how to take care of other people. This is about you, right? And it's often kind of, well, how long is this going to last? Well, in theory, how long is the person going to be dead, right? This is not like we end it in a certain amount of time. How long is this loss going to continue, right? Now, are you in the same phase? No, hopefully more love replaces the pain that's there. I'll give you another example. I told you I was in Charleston this weekend visiting a friend of 40 years. She's a DNP at Medical University of South Carolina. Her son was killed in a car crash at the age of 23, 10 years ago on Thanksgiving weekend. And so she looked at the schedule and the person had scheduled her for Thanksgiving, some kind of block of time. And she said, oh, yeah, if I could have this day off because, you know, that's the 10-year anniversary of or she didn't say 10 years. She said, that's the anniversary of my son's death. And the person responded to her, well, didn't he die a long time ago? Like, does that make a difference when your kid dies? Like how long ago they die? I've had people, you know, in actuality, today is the anniversary of my dad's death, right? And people will say, gosh, you remember that date? And I think, yeah, your dad must still be alive. Because when they die, you remember that. So that loss continues. And it's clearly different today than it was then. But another person put it, grief is like you enter a room and you think, nope, I don't want to be here. And you turn around to leave and the doorknob's gone. It's like, oh, now I'm here. Think about you and what's gone on recently. Think about families who end up walking into the ICU and they see their loved one on a ventilator and they think, oh, I don't want to be here. I don't want to be here, right? So we often say that, you know, this is a test, right? If I can just get through there, I'll be better, right? And oh, that was such a gift. It's a blessing, right? This is not a test. This is not a gift. This is not a blessing. That's for individual people to decide, right? And you can often disenfranchise yourself by saying, oh, this was such a gift, right? Now, there is relief when you had a loved one that you perceived to be suffering. There was a sense of relief when my dad with dementia did die, because I knew he did not want to live in that state. That was not consistent with who he was. So there was somewhat of a sense of relief, but I didn't see it as a blessing, right? And just remember, any sentence that starts with "at least" tends to be useless. Oh, somebody's parent died that was 97 when I was on service last time, and somebody said, well, at least they had them for not, like, no. That just means they've had their parent longer in their life. So skip it. Skip the whole "at least," right? Remember that your grief is not comparable. No grief is comparable. This is not about closure, right? There's no closure for grief. We don't wrap it up in a bow. You know, it's not a piece of pie that if I give you a piece, there's less grief for me. It doesn't work that way. It's hard and it's painful, and it should be without judgment, because everybody grieves in a different way. So anybody who's in palliative care, I think, and hopefully knows Rachel Naomi Reming, and every great loss demands that we choose life again, right? We need to grieve in order to be able to do that. Remember, it's a loss, right? The pain we don't grieve, the pain we have not grieved over will always stand between us and life. And I clearly was seeing that when, like, I yelled at this traveler nurse when kind of at the end of the pandemic, and, you know, and then I justified it like, what an ass, dude, you're just being an ass. And, you know, and I took the time to get up from the provider room and walk to the unit where he was so that I could tell him that personally. Right. And I was like, no, this is not, what am I doing? Right. This is like not me. But that pain was there. It's not me most of the time, I should say. That was unusual for work. I'd already told you that mourning, that's outward, right? That's how you express loss, right? That's behaviors after a loss or anticipation of a loss. That's kind of your public expression. That's your public face. Tangible, that's a permanent loss of life. That's your family, your pet, your friend, your patient. It could be objective, like in Florida right now, they lost their home to that. Symbolic losses, that's a loss of a role. That's a loss of your culture, your identity, your bodily function, divorce, demotion from a job. You lose a person to addiction. That's also ambiguous, right? Because the person's here, but they're physically present, but emotionally absent. Mental illness can be the same thing. There are people who say were raised in a specific religion. They get to the point where they say, this religion is not for me. And then they leave and they lose that whole social network. That's very symbolic. So lots of things can be symbolic, and that's why you don't compare them, right? So it was really a symbolic loss for me in our hospital, in addition to the physical losses that we were experiencing, but most were symbolic, right? And I talked about ambiguous loss, the physical presence, but the psychological absence. So think about someone with dementia, right? Physically, they are present. Psychologically, they may not be there at all, right? And how do you grieve that, right? I felt like with my dad, I couldn't have a funeral, but I didn't have my dad, right? So it's really an ambiguous place to be, right? And then you have physical absence, but psychological presence, right? So children who get kidnapped, people who go missing, war prisoners, those kinds of things. And we know that death is really acknowledged, but symbolic and ambiguous losses, not so much. So, you know, on our campus, we have not had one ritual, not one, to honor what we went through in COVID. Not one ritual that honored the people who died, not one ritual that honored the colleagues that left. And rituals are very important, but we haven't done any of that to acknowledge it. And many institutions have not, because we don't do a lot for symbolic and ambiguous losses. So this is just a nice representation that, you know, grief is inward, mourning is outward. So disenfranchised, as I said, DOKA, D-O-K-A, Kenneth Doka, an amazing, now a professor emeritus who's done so much work in this area. But this is a loss where the survivors are not accorded a right to grieve, right? So go all the way back to AIDS deaths, right? If you were just a partner, right? And the family came along and said, you're not coming to this, the biological family, you're not coming to this funeral, you're not going to, you know, you don't have a right to grieve, you don't have a right to be in the hospital, you don't have a right to be here, and we're going to prevent that, right? Think about people who oftentimes with our patients, right? There are patients. So, we're not afforded the right to grieve that. We're not allowed to grieve that. So there's a wide variety, but you culturally it's been determined you don't have a right to grieve, right? So grief that people experience and they occur a loss, and it is not, or it cannot be openly acknowledged, publicly mourned, or socially supported. And this goes back to, again, the campus where I'm working, and anywhere in healthcare, right? Are you really allowed to cry, right? At this point, your patient that you became so attached to, who's been in the hospital this many times, or or a clinic patient, doesn't have to be an inpatient, that's died, but you've got the waiting room, and we hit your check boxes on Epic because you got to have your satisfaction surveys, yada, yada, yada. Are we not going to publicly mourn that, right? It's not socially supported. We get our grief disenfranchised all the time. We do it to ourselves, and the institution does it, right? So when you speak of disenfranchisement in relation to grief, is to recognize that in various spoken and, keep in mind, unspoken ways, social and cultural communities may deny recognition, legitimacy. You don't have a legitimate right to grieve here, or social support, right? So you don't get any support, right? You're the step parent, right? Or maybe you're the former step parent. You don't get any right to grieve. You're a cousin, right? We tend to keep that to people we define culturally as family, right? So keep all of this in mind as you are thinking about yourself, right? And it's really the social aspect. That's the ability to engage in ritual, the ability to have closure, talk about it, those kinds of things. That's truly where things get neglected, right? Are you allowed to have grief at work? Is it safe to have grief at work? Do you even know how to grieve, right? Most of us don't, right? It shows up, you push the ball in the water in a pool, it just pops up someplace else in the pool. So every institution, every culture, every society has norms, and they tell us how we're supposed to grieve, right? If you're sitting Shiva, if you're, this is what you do. If you, this is what color clothes you're supposed to wear. This is when you're supposed to cry. This is when you're not allowed to cry. If you're a man, you're expected to do this. If you're a woman, we have very specific gender norms to do that, right? If you're in healthcare, you're not allowed to do this. If you work in a campus institution where you've had a lot of, symbolic losses and you want to do a grief study, we don't do that here because we don't talk about that here, right? So all of the cultural and society norms tell us what's okay and what's not. And, they can say this, you're not supposed to feel that way, right? You're not allowed to be angry. You can't think this way. God forbid you have any kind of spiritual expression. That's not okay either. This is all disenfranchised grief. I'm hoping this is starting to kind of, resonate with both you as a human and a provider, and kind of what you sometimes can see what we may do to patients, right? So the relationship doesn't get recognized as important enough to be able to grieve. The loss is not acknowledged, and the loss is not socially defined as significant to you, right? Pet loss, another one, right? Oh my God, it's just your dog. Give me a break, right? Oh, your son died. Well, that was 10 years ago. What's the deal, right? And the griever gets excluded. You get excluded from that process, and that's not okay. So some of the challenges with this, right? Intensified emotional reaction, right? I had that personally, right? More than once during this I don't think I can say, I don't want to say post-COVID, post multiple surge issue, right? The intensified reaction to say, who do you think you are telling me I'm unprofessional? You don't know a damn thing about me, right? And just like, or, ruminating, like, oh my gosh, something's wrong here, and it's intensified, and then I would ruminate about it, right? Or I had lots of ambivalent feelings, like, I don't know if I want to do this anymore. I don't know if I want to work at this place. These people are not the same people, but I love my work. I really want to stay, right? I just, or should I call this person, right? They had a death, but is that more about me? Is that about me or not? Or then somebody would say, gosh, Darrell, thank you for everything you've done during COVID. I'd be, oh, no, don't worry, I'm good. Like, don't praise me. For God's sake, don't praise me. That puts me over the edge. Give me a Starbucks card and we're good, but please don't praise me. That I can't, that's like triggering. And then you have all other crises going on at the same time. Like you've got people are really dying. You're stressed out of your mind because the hospital's packed to the hilt. I feel like now I can't really do good palliative care because I only have like this much time. And, so there's all of those things are happening simultaneously, right? And the ruling power of essentially disenfranchising grief means that if a loss is not recognized as a loss and it's not realized as grief, just directly and magically as powerful as that, right? Oh, not a grief, not a loss, move on, next patient, next person. That's how it works, right? It's just magic. That's just how it happens, right? And it's got a pretty important clinical implication here, right? Unrecognized grief needs to be recognized, right? That's how it works. We have to recognize it. We have to acknowledge it first in ourselves, right? Because if I'm only working at 75% because of grief issues, my patients are getting 25% less of me. My family is getting 25% less of me. So I had to flip the switch and say, really, this has to be about you. You have to somehow make this work, acknowledge this grief, and you can't depend on the institution to recognize it for you, right? And once I kind of made that shift that I'm contributing to this disenfranchised grief because I'm expecting something else to happen, yeah, that was a huge shift for me. And it wasn't a quick one. So when we don't have a sanction to grieve, right, injury to the self can occur, and it can affect your identity and your self-worth and your self-recognition and other senses in which, the self just can't be you, right? And this is where it comes out to be, you're just burned out. Be more resilient. Can you just meditate a little more? Take some time off. Sure, if you take time off, the rest of your colleagues are going to have to pick up your workload, but really, that's what we're telling you to do, right? That's just, here, have a pizza party. Can you just please have a pizza party? That's really all we need. Except you'll all have to eat that pizza in different rooms because you can't have your mask down at the same time. But, but don't talk about grief, and for God, don't cry. Come on, people. So in the workplace, in the aftermath of a loss, think about this loss, grieving providers and staff are going to need varying recognitions of support, right? So I don't need to be called up in front of people and say, thank you, Darrell, and everybody clap. That, again, that would put me over the edge. Everybody needs different things based on your relationship with the loss, right? We only grieve those things which are significant to us. We tend not to grieve those which are insignificant. Do we acknowledge, right? So nurses and physicians in the ER, someone comes in coding, they code them, they were coding in the field, they code for in the ER for 20 minutes and they call it, right? They've never seen the patient, they don't know the patient, they can feel bad and they can feel bad for their family, but that's going to be very different than somebody you've known for a long time, someone's family you've known, that's very different. So to say one size fits all for the recognition of grief is to say you don't know what the hell you're doing. So it's got to be unique, right? So rituals, some people are ritual people, some people are not. And in addition to deaths, providers and staff can experience many losses, which is what I've been talking about the whole time. How many of you feel like your culture is the same as it was pre-COVID, and how much of you and how do you like it, right? And providers, sorry folks, we represent people. And so we have typical responses to grief. We are not exempt. And I know it'd be nice to think that we're all exempt and we're healthcare and we have a different standard, but in the end, we're still human and we're still going to grieve. That's just like everybody else, right? So COVID and cultural changes have left people feeling, staff and providers feeling, they've lost the employer they once knew. I've spoken about this in multiple places across the country, and everybody agrees this is not the same place. Many people have left, say, this is not the place I used to work and I don't want to be here anymore. These are not the same, because often where we work is the people, right? I don't work with the same people anymore. I don't want to be here. This is not what I want, right? And I feel that way. I do feel that way on some levels and on others not. So, and it's really typically disenfranchised in the workplace because the norm says grief doesn't belong at work, right? So go do your exercise outside of work, go do your meditation outside of work, go do your yoga outside of work, go on vacation, but don't bring that crap here. Don't bring your grief here. It's important, but not important to bring enough here, right? That's like that kind of, it's politically not correct to not support grief. It's politically not correct to say, oh, I don't like palliative care. I don't, but then they turn around and not fund palliative care but it's not politically correct to say you don't like palliative care. So Workplaces really exercise significant pressure on grieving individuals to be quiet and to hide their grief. And you would think in healthcare that would not be the case, but it is. So we are really good at disavowing grief. Yep. It happens to all of us, right? No, I don't, that doesn't bother me. I'm fine. Like, fine, right? Feelings inside not expressed. Every time I would say that during COVID, I'm fine, which in my mind, feelings inside are not expressed. And that's, it's just not a safe place for us. And we've also been taught that grief is not safe. And for the most part, we weren't taught about grief, right? And that data comes across fully, right? So it doesn't matter if you're a counselor, it doesn't matter if you're a social worker, it doesn't matter if you're a nurse practitioner, physician. We know that in general curriculum, you do not receive much on grief. You get some different, social work, you can get some different theories on grief, but really who cares if you're following Warden's theory or you're following Teresa Rondo, that you learn their theories. So what? You don't learn how grief impacts you and how to grasp, that's all ongoing education. So then we were thrust into the environment, but we really haven't been taught about it. Other than to, someone tries to give you Kubler-Ross theories or, and Kubler-Ross theories were actually about the living, not the dying. And then they kind of moved them to the dying, and it's nonlinear. Anyway, so we rarely openly grieve the death of our patients. Most of the time, palliative care has a ritual. We do have a ritual on our campus. We write their names. We have a bell that we ring and we say their name out loud, and it's whoever's on service at the time. And then the person who comes on the next week, we can see who died, and you can do the same thing. That's just our small ritual. But it's very rare that we openly grieve patients, right? Very rare. I do a memorial card for the entire hospital once a month that lists every single person that died, what unit they died on, and how old they are or were, and with a very special grief saying on the front, different each month. And I send that to the entire hospital and the entire clinical staff. And the number of people who respond back every month and say, thank you for sending this, just because it provides people an individual ability to kind of think about that, right? There's a lot of evidence to support that we in healthcare distance ourselves from the normal grief experience because we don't identify with seriously ill patients, right? We think of them as the person with COPD. We think of them as liver failure, and they drank too much, and that's how they got their liver failure, and then COPD, and they smoked too much. And, we kind of, that's a survival mechanism. We give denial a bad rap, but denial is also a good coping mechanism for many families who can only, or individuals who can only handle so much. So they go in and out of denial. Cumulative grief, multiple sequential losses usually goes unrecognized, right? Palliative care, we do a little better job of that. Long-term care, terrible. That long-term care deals with lots of death, and lots of that goes unrecognized, unsupported. It's often disenfranchised by our own family. Like me trying to have a conversation. First of all, I was successful in making sure my kid, indirectly successful, my kid wants nothing to do with healthcare. After years of dinner table conversations of that, oh, what happened at work today? That's so sad. Next, right? So your own families kind of don't recognize. Friends, what do you do for a living? Oh, that's so sad. Well, actually, no. Community, the healthcare system in general, it's just so kind of not honored and recognized. And then there's this wide variation, right? Some people, they are able to express it. Other people don't express it. Sometimes they correlate with, this is something that happened in my life, and I'm not really being able to identify that this person reminds me of my grandmother's death, my brother's death. My brother died last December of pancreatic cancer. So people in their 50s who have pancreatic cancer for the last year, I've had to be really attentive to, okay, right, let's see, shift through, what is this about? What's that not about? Those kinds of things. So, and again, as I said, the intensity of a healthcare provider's grief response is related to the intensity or duration of contact, right? So who generally in the hospital setting has the most contact with the patient during that hospital stay, right? So it's you, especially if you have an ICU death, it's generally the nurse. And generally the nurse spends 12 hours a day. And sometimes if it's to say 3 days, they may spend, 36 hours in a row with that patient and family. Otherwise, it can be primary care providers who've cared for people for years. Some of my longest standing patients who have major neurocognitive disorder, I've been their primary care provider, one now for almost 8 years. So it's about how long and how intense, right? Taking somebody, a mother of someone who's had an overdose, who's got a noxic brain injury, who's going to end up being an organ donation, and all of this happens in this miraculous time frame of 2 days, 3 days. That's very, very intense. So it's the intensity of that, right? And then it happens and you move on, right? So when we fail to deal effectively with the reality of dying and death and loss, we risk disenfranchising the grief of not only the dying person, right? So, oh my gosh, their son was a drug addict. They knew he was a drug addict all this time, right? That's disenfranchising because we don't recognize what this means to them because we're so busy and dealing with our own stuff. And we also don't recognize the grief of primary and secondary caregivers, right? Cousins and other people and, you know, all of those. So it's so important in how it spills over, right? So when we don't deal openly with loss, we just reinforce denial, right? Avoidance, death, we're a death denying society, we're grief illiterate. Another one I saw was mourning, it wasn't mourning avoiding, but anyway, and this just reinforces that we can control death. Death's an option. And we support institutional, like, okay, we've got 10 people boarding. This person died. Thank God. Is the family coming in to see the body? No, let's call housekeeping. Oh, okay. The system is designed to get the results it gets. And that applies to grief as well. But you have to take pause and say, wait, let's just take a moment here, right? So what do we do about this? So we want to make sure that it's recognized. This is empathic failure, right? Empathic failure, think about that. They don't have empathy. And that can be the institution, that can be family, that can be friends. It's recognized as empathy failure, right? On a most individual level. You can also experience self-empathic failure, right? You don't have empathy for yourself, right? And the central goal of clinical and self-assessment in grief is to understand where this is going to happen. Where is empathic failure going to arise? I know on our campus, it's going to arise with the administration bigger picture of, we're not going to talk about this, right? We're not going to have ritual about this, right? And then if we want to bring up ritual, politically correct, we have to have the right person do the ritual, right? Maybe they're not good at rituals. Maybe that's not their thing, but because of their specific specialty, they've got to be the one that does it. They've got to be the one that says, yes, we can do it, or no, we don't. They don't know diddly squat about grief, or they know a little bit about grief, but politically, that's the person that, we don't want to step on anybody's toes, even though it can really affect whether we have empathic failure or not, right? So that also gets in the way. And if you're hesitant to express grief, the longer you're hesitant, the more silent you're going to be. It is absolutely going to lead to silence. How many of you are hesitant to express your grief and then you just go silent about it, right? Where do you think that goes? Into the air, right? That's energy. That's energy that comes into you that's going to show up someplace else. If it's the little old man who cuts you off on the way home and you're screaming and yelling, and the poor guy doesn't have any idea what he's doing. If it's the traveling nurse who made some nasty comment and you go around the corner and scream at him, if it's your kids, it shows up, right? And so you can be silent about grief, but that doesn't mean grief's going away. So rituals are so important. First of all, grief requires witnessing, right? So you have to companion someone with grief, right? I don't need to, people in grief don't need help, right? Grief is not a pathological response. So they don't need my help. I'm not a helper, but I need to be with them. I need to companion them. And I needed someone to companion me when I was going through this grief. And it's yet to truly happen within the organization, right? I had to go outside of the organization to say, this is awful, right? Because inside of the organization, all I got was, you can't yell at people and that's not okay. And what's wrong with you? And, like the typical grief illiterate healthcare system. So rituals are very symbolic acts and they confer transcendental significance and meaning of certain life events, right? That could be a funeral, that can be a celebratory, that could be a baptism. It's symbolic. Rituals are symbolic. The blessing of the hands is symbolic. It's so important. And rituals allows community, as you define it, to come together, to witness, and then to interpret, individually interpret that event. And so many disenfranchised losses, there's just no ritual. Right? How many of you have had a ritual around the losses that went, the personal losses you experienced around COVID? Right? Not there, doesn't happen, but impacts how you take care of patients, impacts how you live, impacts if you're going to stay in the profession or not. All of that is impacted, right? This isn't burnout. This isn't compassion fatigue. I can't stress that enough. And this is not pathological. This is not pathological. There is nothing wrong with us. We are grieving. Right? Early grief is 2 years, right? Now, even though you get your big 3 days, if there's a grief, if you have a loss of physical, tangible, a death, you get your 3 days, right? And your colleagues will have to scramble to cover for you during those 3 days. Early grief is at least 2 years. And that's how I define it. So rituals are powerful therapeutic tools. They can enfranchise, you can feel acknowledged, you can, it's so important to name what is happening. We have to name it, right? But the problem is in institutions and cultures, if you name it, then there maybe have something we have to do about it. But step one is simply just witnessing it. I am grieving. And to say, I see you grieving. I don't know what to do about that, but I see you grieving, right? It is really vital that we be able to name that loss, right? So this, one of my favorite quotes, it's that it is not only for what we do that we are held responsible, but for what we do not do. If we do not grieve, if we don't acknowledge our grief, if we don't do that, then we are responsible for that. Same with institutions, right? And I, again, have to say, the pizza party doesn't do it. The Christmas blanket didn't really do it for me either, but, so be it. So this helps. Continuing education. I immersed myself in more, and I just couldn't get enough and still can't get enough. I am very hesitant to use the word self-care, but it's important and I like it, but I don't use it as a punishment, right? So if you haven't seen me in a while, you see I've lost a lot of weight. I mean, I've been up and down. My obesity got out of control during COVID, and I walk 3 to 4 miles every morning at 4:30. I haven't missed a day in months. I did it this morning before I even came here. My self-care, that probably doesn't work for you, or it does work for you. I don't know. Professional support systems. Myself and a colleague from SCCA got together and we said, we've got to do something. So we formed the Pacific Northwest Association of Palliative Care Nurse Practitioners. We just started collecting emails, and we have 63 members, and they are nurse practitioners in palliative care from Alaska, Washington, Idaho, Montana, and Oregon. We meet once a month. We put it together. I said, I have got to do something about this. And then I formed a national group of palliative care leaders, because it helps me to be able to talk to them and to be with them, and to know there is post-traumatic growth and vicarious resilience. So I see other people being resilient, and I know I can. And certainly my post-traumatic growth has been all about grief and loss, and immersing myself in it and standing up for what I believe in, and, which is not always popular, but I don't care at this point in my life. You want to get rid of me, get rid of me. I've made my contribution to the world. I can get a job anywhere. I don't need that anymore. The system needs me more than I need the system. And it only took, 32 years to get there. So not everything that is faced can be changed, right? But nothing can be changed until it's faced. So I hope you've all seen this before, but the journey of 1,000 miles begins with the first step. So grieve well, my friends, and I will stop sharing and be open to, there's references that you have there to any questions. There's more. There's not a lot of recent stuff coming out on grief. Nobody's really interested in a lot of grief research. So that's why I'm hoping our national study will be a beginner for looking at all disenfranchised grief in healthcare. So thank you.
Thanks, Darrell. I am going to open it up for questions, so feel free to either raise your hand or unmute yourself. I'll keep an eye on the chat as well. Shanitra is posting the link to an evaluation form. So we have those for all of our grand rounds and our grand round speakers. So again, thank you so much, Darrell. And I am going to open it up and feel free to unmute yourself if you're more comfortable putting your question in the chat. I'm keeping an eye on the chat as well, and always feel free to put your hand up. And yeah.
Oh, I'm just seeing that Tama's on here, Andrea's on here. All these people I haven't seen forever. So come on, I won't scream. You can ask your questions.
I think it's also a lot to process and digest, because we've all, I think, been living this and been in the midst of the disenfranchised grief. And I see Dawn, your hand is up. Go for it.
Yeah, thank you so much, Darrell. I'm a palliative care doctor at UCSF and have been, I think, like many people, immersed in grief and inventing around it as a result of need in the pandemic. And I noticed at the same time as the pandemic's impact has been evolving, the formal introduction of complicated grief as a diagnosis also came into our midst. And I've read a lot of debates around the idea of making grief a diagnosticable entity, as in an illness or a medical thing, and others who say don't pathologize grief. I have found, actually, particularly in the healthcare arena where we speak in the language of medicine, that actually calling grief an injury that requires the same time and attention we would allow for healing of a visible injury makes a lot of sense to particularly people in the healthcare field. And I wonder your thoughts around that.
So first of all, I'm in the category that I'm not a fan of pathologizing grief, but I understand that people want to bill, right? So we had to make a complicated grief. And so, the system is designed to get the results it gets. So we put a ICD-10 code to it so somebody can bill for it, whatever. I do like that idea. There's also a concept out there called soul injury, right? Which also kind of fits close to that. And yes, it is an injury, right? Doesn't mean there's pathology, but it means there's something there that injury needs to be healed, right? But you're absolutely right. That's not a visible injury, right? Because it depends on your mourning behavior, right? So how you express that. Mine certainly was not socially acceptable, right? But nor is crying. But I like the concept of, it's a grief injury, right? What do we say when someone falls and breaks their arm, right? It's an injury. It's got to heal. What do we have interventions for that, right? And making specific, the primary intervention is that grief needs witnessing, right? People need to tell their story. And you'll see people say the same thing over and over and over and think, oh my God, you're talking about this. Well, that's because they haven't felt heard. And when they feel heard, they'll stop telling you. So yeah, great, Don, great. And I love your colleagues. I'm very close to some of them there. So.
And David also has his hand up.
Good morning. Thank you.
How are you, my friend?
I wonder if you could comment a bit on how to respond to people who, whether well-intentioned or perhaps maybe not so well-intentioned, say things that have an invalidating effect. It seems somewhere on the spectrum of a microaggression when this happens. And I'm wondering if you have some thoughts about tools to respond both internally, but also to put that out externally to, you know, in the way we might with a microaggression that we acknowledge as such. Does that make sense?
Yeah. And so, I try to follow the path that I try to be curious. Like, so people's behaviors make sense to them. That's why they engage in those behaviors. They may not make sense to me, like, where are they coming from? But that then requires me to be curious, to think, gosh, where's that coming from? Where's this? So I've tried to be more insightful. And I've also remembered that I'm responsible for my triggers, right? So I'm not going to say you're triggering me. No, I have to own that. And I'm the only one that can violate my boundaries. Right. So I then think, like the person who said that to my friend, the person who said, oh, didn't he die a while ago or something like that? So how do I respond to that in an open and acknowledging way that's not aggressive back? Is, yes, he did, but the loss of a child is really important. And this time is really important to me. Right. So kind of not, thinking, I sometimes venture between, is my job to correct you, or is it just my job to make sure I don't violate those kind of boundaries? And so I think it's so individual. First of all, the dynamics of the relationship, right? Who's in the power dynamic of the person saying that? And is it safe to respond to them? Or are they, you don't want to give somebody a pass, like, oh my God, they're just an idiot all the time, so I just expect that from them. But at the same time, you really kind of want to sort through, did that just violate a boundary of mine? Where do I want to go with that? And how much energy do I want to invest in that? But oftentimes just some little educational piece, like, gosh, that's, it really actually, it makes me, angry, because I show anger when I'm grieving something, right? So some kind of education, if you feel like it's worth the investment. If that's helpful.
I again want to just thank Darrell for bringing his authentic words and wisdom to the space. And again, thank you so much, Darrell, because I think, again, it's something that we just probably don't talk about enough or hear enough about. Yeah, it's not, I think it's also, it's not the easiest topic to talk about. So thank you for bringing it to our space. And
My pleasure.
Shanitra will move those of us who need to move into our breakout